Good morning, everyone. I would like to thank the organization committee for allowing me to speak today. The fetal to neonatal transition and the transition to the independent life thereafter is an interdependent sequence of physiological events and includes a respiratory as well as a cardiovascular transition. During the respiratory transition, the infant has to clear the air liquid, has to achieve lung aeration and facilitate gas exchange, and then continue to have spontaneous breathing. The good news is that the majority of infants do that without our help. 80% of infants, in particular premature infants, breathe and cry at birth, and whenever they breathe or cry, they use different breathing patterns to aerate the lung. Unfortunately, 10% of newborn babies need help with their breathing, where we have to step in. Now, when infants fail to initiate breathing, the goal of the breathing support is the same as what the respiratory transition would do. With the breathing support, we have to clear the lung liquid, we have to establish functional residual capacity, we have to facilitate gas exchange, we have to stimulate breathing, and by also delivering an adequate tidal volume. Now, whenever we do this, we have to find ways to minimize lung injury. Now, what are the current recommendations from the Resuscitation Guidelines, or NRP? They tell us we need to use positive pressure ventilation. We should adjust the flow meter to 10 liters, pick a pressure around 20 to 25 centimeters of water, and if we should use an initial PEEP of 5 centimeters. Why that? Because this will help us to have the baby's lung, when they inflate, to keep the lungs inflated during those positive pressure inflations. Now, the main focus today will be around the peak inflation pressure, which is around 20 to 25. Now, we said when we use positive pressure ventilation, we have to deliver an adequate tidal volume while minimizing lung injury. Now, if you look at this pressure to tidal volume relationship, you can see that with any chosen pressure, your tidal volume delivery is quite variable. It could range from 0 to up to 38 mils per kilo. Now, this is rather concerning that regardless of the pressure using, your tidal volume can vary widely. And there's many reasons why the tidal volume could vary widely. It could be cesarean section without labor. It could be premature rupture of membrane for several weeks, as well as other reasons. So there certainly is a lot of variability in the tidal volume delivered with any pressure you may choose. Now, why is that important? We know from animal studies that when you give only 6 large inflations with up to 35 mils per kilo, you alter your response to lung aeration, you alter your response to surfactant. So you certainly see that when you use normal tidal volumes, like less than 8 mils per kilo in those lambs, when they were attached to a ventilator, that the volume delivered and the pressures used is much improved. We also know that when you use a high tidal volume, a high tidal volume, you certainly get a lot of damage into the lung, and it is not per se that the pressure is the problem you have chosen, it's the volume. And this really nice experiment where rabbits had a cast around their chest versus no cast showed when the chest was allowed to expand, aka delivering a high tidal volume, more injury occurred compared to when the chest was not allowed to be expanded and just high pressures were delivered. Also, in particular, important for preterm babies is that your total lung capacity and functional residual capacity is really, really small. And the difference is even smaller. So tidal volumes greater than 8 mL per kilo would distend the lung above total lung compliance, total lung capacity, and can cause damage. So now the recommendations say we should use a pressure of 20 to 25, and as I just shown you before, this might be the pressure variation you will see using a pressure of 20 to 25 centimeters of water. Now, has anything changed in 2022 from the recommendation? Now, this was just out for public comments, and the treatment recommendations for using a respiratory function monitor in 2022 hasn't changed from previous statements where it says there is insufficient evidence to recommendation for or against the use of a respiratory function monitor in newborn infants receiving respiratory support at birth. There is low certainty of evidence. Now the question is that true? Is there anything ILCOR might have missed, or maybe we should use it, and we will discuss this in the next 20 minutes or so. Now, what is a respiratory function monitor? A respiratory function monitor is nothing else than a monitor where a flow sensor is placed between the mask or endotracheal tube or laryngeal mask and a ventilation device. Most commonly, everyone has seen it in the NICU, where they are attached to a ventilator to guide mechanical ventilation. Now, if you use a standalone respiratory function monitor, which is the approach currently used in research settings, in delivery rooms, in several centers. So those devices, they continuously display airway pressure, like the peak inflation pressure and the positive end expiratory pressure. They can display gas flow and tidal volume, as well as respiratory rate and minute ventilation. And they also can display leak. And the leak display is either instantaneously, it's changing with each inflation, or is changing over 20 or 30 seconds average. Now, given that there is a great interest from a research perspective in respiratory function monitoring, there's several systems who have been developed which are used to study respiratory functions and how respiratory function monitors can be integrated into neonatal resuscitation. Now, how can a respiratory function monitor might help? Well, it can ensure that you have a good mask position and seal. It can help doing training. You can evaluate positive pressure ventilation, like you can look at what your tidal volume is, your expired, what your inspiration expiration time is, what your minute ventilation is, your airway pressures, if you have leak. And there's also some evidence out, but we will not talk about this today, because you could confirm your endotracheal tube placement. Now, when you look at the respiratory function monitor screen, and depending on what setup you use on your screen, there will be several things you will see. Like on this screen, what I have here is where you have the ventilation pressure on top, you have your gas flow, and you have your tidal volume on the bottom. Now, the ventilation pressure in red, you can see there's a certain baseline pressure of 5 centimeters of water, which is your PEEP, and with an inflation, it goes up to a set pressure, and in this case, it was 30 centimeters of water. The flow, again, goes up, which is the flow going towards the infant. At the end of inspiration, the flow comes back to 0, and there's an expiration, which is basically the flow away from the infant. And then this is also always reflected in the tidal volume, and most important when you look at the tidal volume wave is that you want that the tidal volume wave goes back to 0, to the baseline, because that would indicate there is no leak. If it doesn't go to baseline and resets to the baseline, this would indicate there's a leak, and we will get to that in a moment. Now, before we go to discuss how the respiratory function monitor can help, I would just wanted to do a sidestep on something else the guidelines tell you, because the guidelines tell you that whenever you do positive pressure ventilation, you should adjust your ventilation by assessing the heart rate and chest stress. Now, while heart rate certainly is the best indicator to assess if your mask ventilation is successful, chest stress might not be the easiest way to assess if your mask ventilation is adequate. One of the reasons is that, particularly now with having infants in plastic bags, it might be even more challenging to see if the chest is moving. But regardless, studies I've done myself as well as other people have shown that operators, when they stand at the head of the table and perform mask ventilation and while performing assessing chest stress, struggle to do so. In fact, as you can see here, regardless of the volume delivered, they were really struggling to assess how much the chest is moving. Now, you could argue, well, okay, it's hard when you stand at the head of the table, but what is happening when I stand at the side of the table, or more experienced, like I had the junior staff or the junior trainee or the trainee at the head, and I am as a attending are at the side observing the whole situation. I have to disappoint you. Regardless if you are a junior trainee at the head of the table or you are a attending with more than 20 years experience, your assessment of chest stress is as bad or as good as ever you want to put it. So in summary, it doesn't really matter because you're unable to assess chest stress in those premature infants. Now, the tidal volume you deliver, and when you ask people what they think they do, is also quite variable. And as you can see here, the red bars indicate what people were thinking the tidal volume was they delivered, and next to it is actually what was measured at the same time. And you can see there's 5 bars of tidal volume delivery where people were unable to assess the delivered tidal volume. So the message is clear that it is really difficult for any person who does PPV to assess what the tidal volume is when you provide mask ventilation. And there's many reasons for that. You have a change in compliance from birth. As the liquid clears, your compliance is changing dramatically and rather quickly. So it is really hard for you to be on top of the game and always identify how much volume goes in particular when you use a T-piece. Now, people will say, oh, well, you know, we use a flow inflating bag. We can feel that. And I can only say that might be true. Unfortunately, there is extreme lack of studies using a flow inflating bag, as no one has ever performed any of these respiratory function monitoring studies using flow inflating bags. Now, how can a respiratory function monitor help? And one of the pitfalls we come across quite often with mask ventilation is mask leak. Now, one of the main reasons for mask leak is often that our mask sizes don't fit properly. And we know that from mannequin studies that there is variable mask leak, and this is irrespective of training. When you do look in the delivery room, we will also see that the majority of babies have high mask leaks. They often occur more at the beginning of the mask ventilation. When you look at the mask leak, you will see that the tidal volume delivered is reduced, is unstable, quite variable. And it often also varies between resuscitators. Now, if you would have a respiratory function monitor, and I just want to look you at the top right side of the slide, you can see again that you get the pressure, which is set the same way, 30/5 for PEEP and PEEP, gets delivered. But you can see that the flow, and in particular the tidal volume waveform, looks rather different compared to the left. And now what you can see is that the tidal volume goes in, then abrupt because the I time is over, the flow end is resetting to expiration. You see the concave waveform of the expiratory volume, and then you see a straight line resetting to go to zero because the next inflation starts. Now, the main question is, okay, I can see there is sleek, but you can see that the straight line where the tidal volume resets as different sizes, at different heights. Now, one of the questions would be, okay, could I use this to assess how much leak I have? And the short answer is unfortunately no, because if you would like to know the leak, you would have to do a calculation so you get a percentage. Because if you look at those three blue lines and where they reset, the leak in all three of these inflations is 80%. And this is rather than challenging for an operator to observe this, or even for a team lead to observe this and then really understand that the mask leak is similar in all inflations. But what is striking is, and it's an important message for the delivery room, is that despite a leak of 80%, the pressure we're delivering is still set. So you could have a leak up to 80% and still delivering an adequate pressure, but not delivering an adequate tidal volume. And if you look at the bottom, this is a classical example where there is 100% leak. Someone is lifting the mask, repositioning it as part of the Mr. Soper steps, and then you get a beautiful mask ventilation with no leak or hardly any leak. And at the beginning, you can see that because the leak was around 100%, that you don't achieve the pressure. But keep in mind, if you get 80% leak, you will still achieve the pressure, which can be falsely reassuring if you look at the manometer and you can see that the pressure is still achieved. Now, does the respiratory function monitor reduce mask leak in the delivery room? The answer is we don't know. Why is this? Well, I put this slide up from the first RCT on using a respiratory function monitoring in the delivery room published, and there was one I did during my PhD. And what you can see is that there was a significant reduction in the mask leak, and it reduced from around 54% as median to around 37% median, which is nice. But if you look at two other trials which also have been published since then, you can see that in two trials the leak was reduced, and in the third trial the leak was not reduced. It was slightly higher compared to the control group. So that certainly tells us that a respiratory function monitor has the potential to reduce mask leak, but maybe not necessarily the approach which has been chosen so far was a successful one. What could be the reason for that? First of all, one thing we're not really 100% sure is what is the best holding technique for face masks on an infant's face. I picked this pictures from a study which is 15 years old now, and it's the latest study on optimal face mask position. And this is a mannequin study where it actually showed when you use the mask as it's held in the left picture, you have the least amount of leak. But no one has done a follow-up study in the delivery room, so we don't know if this would also be the same in the delivery room. And certainly this is an area where more research is needed. Also, what is quite interesting is that when you teach neonatal resuscitation and using a respiratory function monitoring during teaching, you will be able to reduce your mask leak quite significantly, as you can see, which is a great achievement, so that when you train mask ventilation using a respiratory function monitor, you will be able to reduce the mask leak. So you assume you have a better mask ventilation performance, but as I showed you earlier, in the clinical trials. Unfortunately, the same isn't true for clinical trials. However, now there could be many reasons why this is the case, and certainly there needs further studies, but as it looks at the moment, it can help for reducing leak during simulated ventilation, but maybe not in the delivery room. Another pitfall which I want to discuss is airway obstruction as well as glottis closure, and I just a couple of slides for that. There was a long time, particularly in the last decade, there was always talk about that you could have airway obstruction, that many of the infants, when you provide positive pressure ventilation, you have obstructed airways. Why are we having this? One of the reasons is maybe that the head is not in a good position, or we, slamming the mask too hard onto the infant's face. And there were different approaches used to assess airway obstruction. One was using a respiratory function monitor, and the other one was using Untitled CO2. And both describe the same things, and more recently, thing which was getting more traction was glottis closure, where due to hypoxia, the vocal cords abduct and close the trachea. So even if you provide mask ventilation, no air goes into your lung. And if you look at the waveforms in B, what you can see on the left in B, you can see air goes in and then nothing moves and air comes out at the end of that inflation, which looks striking similar to the image on the right, which is airway obstruction. So that certainly puts into question the previous thought that there is airway obstruction, because maybe what those studies showed wasn't airway obstruction, it was only glottis closure. That's further supported by a recent RCT, which actually reported that 0 infants had airway obstruction, which potentially supports the previous slide that it wasn't airway obstruction, it was glottis closure. Good. Now, delivery of the tidal volume during positive pressure ventilation, we said we assess heart rate increases, which is the most reliable, and then we have chest wall movements. We're not routinely monitoring the tidal volume we deliver. We use a set PIP, which the assumption it will deliver an appropriate tidal volume. The optimal PIP will depend on lung compliance, which varies according to many different reasons. And if you use a fixed PIP and then subjectively assess heart rate changes as well as chest wall movements, you might under or over ventilate. And you've seen this slide before, that where you can see that the tidal volume delivery is quite variable. Now, how can a respiratory function monitor help with this? And this is a classic example which would go along the way of Mr. Soper as well, where you start, in this case again, with a PIP of 30 centimeters of water. You have extremely stiff lung, and you deliver tidal volume of 1 ml per kilo, which is certainly not enough. So what did the team do? The team increased the pressure to 42 centimeters of water in that case. And what does it do? It delivers a tidal volume from 5 to 8 mL per kilo. Now, maybe there was still no increase in heart rate, but because the team was not aware of the tidal volume delivered, so they increased the pressure further to 50. And then suddenly the tidal volume was 14 mL per kilo, because either the lung was aerated and the compliance changed. And certainly at that time, someone should have then weaned the pressures again, because the tidal volume delivery was quite extensive. Now, and this is again a similar example where the team had a respiratory function monitor available, and you can see that again they started at a PIP of 30 centimeters of water with a tidal volume of 3 mL per kilo, and wasn't good enough, so they increased the pressure to 40 centimeters of water, and suddenly with that the lung opened up and the volume was 10 mL per kilo. Once they recognized it, they weaned the PIP quite dramatically to 20 centimeters of water, and the tidal volume delivered at that time was 5 mils per kilo. So that's certainly a way how you could use a respiratory function monitoring to guide your tidal volume delivery. Now, did that work in randomized controlled trials? Yes, it did work. In all of those 3 trials available, the tidal volume delivery was narrower. So there's the interquartile range of the tidal volume delivery was narrower and more likely within your tidal volume target range. So certainly that worked. Unfortunately, when you put all these trials together in a meta-analysis, the reduction in the delivered tidal volume did not result in a change in chronic lung disease, which is close to significant but not significant. However, it significantly reduced the tidal volume delivered over 8 mils per kilo. Now, I know there will be some questions asked to the audience during that talk. I ask a similar questions about if anyone in the Twitter community would be interested in having targeted tidal volume delivery in the delivery room and what tidal volume range they would choose. And the majority of people wanted it, and they would like to target 4 to 6 mils per kilo. So there is certainly an interest in this, but it's a Twitter survey, so I don't know who answered it. So I don't want to say that it's really scientifically valuable, but certainly the people who answered the survey were the majority who would like to be able to target a tidal volume delivery in whatever way available. Now, what is the problem from a human factors perspective to integrate a respiratory function monitor in the delivery room? Now, there's a couple of studies out so far only to assess what it means to have all this equipment, including a respiratory function monitor, which you can see here right in the middle, below the, right to the left of your resuscitation table. And what the problem is that there's a lot of time people, when they stand on their head and using all these technologies, that they look away from the baby. And as you can see, it's only in 35% of the time, healthcare professionals at the head of the table will look at the baby. The other times they will look at all the monitors. And again, from one of these randomized controlled trials, where they also added eye tracking glasses into the delivery room, what was quite striking was that when they had a respiratory monitor visible, the percentage of the time people looked at the infant was only 29%. When they didn't have an RFM, it was 46%. So certainly it increased the amount of time people were focusing on the baby when there was no RFM present, which I think is important outcome, because one of the most important things is to really look at the baby to assess what's going on and maybe have a team leader who could feed back all this information from these monitors. Regardless if a monitor was used, none had an impact on an outcome of mortality in this, or death before discharge, using a respiratory function monitor or not, which begs the question, now we're using this technology, it doesn't really reduce lung injury, it does not also decrease mortality, so is this technology we should use? And also ILCO was saying, we don't know yet, so hold tight. But what our meta-analysis found, and what the ILCO also described in a similar way, and so far I just wanted to put that out because we don't know yet if this is just a co-finding or is there any causality behind it? The recent meta-analysis of using those respiratory function monitoring trials showed that brain injury, which was a combination of IVH and PVL, as well as IVH, but not PVL, was significantly reduced when a respiratory function monitor was present. And the background for that is that more and more animal studies, as well as a couple of human observational studies shown, is that when you deliver high tidal volume, you can have a fourfold increase in brain injury in those extreme premature babies. So maybe the respiratory function monitor is not so much about reducing BALI or ventilator-induced lung injury. Maybe it's more a tool in the future where we can help to reduce brain injury, which would be as exciting as using it for reducing lung injury. Now, in summary, mask ventilation is difficult. You will often have a leak. Airway obstruction might occur, which might be glottis closure instead of airway obstruction. If you use an RFM, you can identify mask leak, airway obstruction, or glottis closure. Now, the respiratory function monitor reduces tidal volume delivery, but does not reduce BPD or mortality, but it might have a role in the future to reduce brain injury. Now, I would like to thank the organization committee for allowing me to speak today, and I'm looking forward to answer any of your questions. I just put down my information if anyone wants to follow me. I will also post that talk on our YouTube channel in the next days. I would like to thank everyone at CSER for all the hard work, because without the whole team, none of the stuff we do would be possible. And I'm happy to answer any question. Thank you.